Hello everyone, welcome to the Voice of Nursing. My name is Adrian Tracy, the CEO of ICG Medical. Today we're very lucky to be joined by Victoria Cuthill, lead nurse at the Polyposis Registry at St Mark's Hospital. Welcome, Vicky.
Hello, welcome. Thanks for inviting me.
You're very welcome. Tell us a bit about yourself and about the role that you're doing at the moment.
So, I'm a lead nurse, I'm a specialist nurse, and I am very lucky to be the manager of quite an unusual unit called the Polyposis Registry. So what does that mean exactly? We're the only unit in the UK that specialises essentially in people who have an inherited condition where they get polyps in their gastrointestinal tract or in their gut, and this leads them to having a high risk of cancer, essentially. So it's an umbrella term for a range of conditions that are inherited.
Very interesting. Tell us a bit about how you got into nursing.
I didn't know that I always wanted to be a nurse. I didn't really know what I wanted to do when I was a teenager, but I knew that I didn't want to be in an office job. I had this real thing about not wanting to have a boring job. And when I was thinking about what to do, my mum is a nurse, and she would tell me stories about her work, and it always seemed so interesting. She had lots of funny stories to tell me, and I just thought that was something that I could do that would be really interesting, but also be really useful as well. There was a caring side to it, and I just thought that was the job for me, really.
And how did you get into it? Did you go down the degree path? Was it a secondary career type thing?
Yes. When I was at school, I have to say, nursing wasn't ever really mentioned as a career option. It was more along the lines of law, medicine, the traditional roles, which I think is a real shame, because as we're going to talk about, nursing is a fantastic role, and I think schools need to be promoting it as a fantastic career option for young people. So I was sort of slightly put off, I think, by school, but I decided to forge ahead. But I decided because of that to do a degree. All my friends were going to university and doing a degree, so I thought I would go into the university side of things, like the school seemed to be promoting, but that I would also do my nursing training during that, and I'd come out, unlike so many of my friends, with an actual role that I could then, start working straight away. So I actually trained just around the corner at King's College in London, and did a 4-year nursing degree, and then obviously started work straight away after that.
And talk us through the career, ending up in where you are now.
Well, I would love to say that I had a really brilliant career plan, and I planned it all out when I was at university, but quite a lot of my roles have just sort of come about, and one has followed on from another. So as part of my degree, we did a really fantastic management placement as our final placement. We were doing all our placements at St George's Hospital in Tooting, and I was working on a respiratory medical ward, and I just did the slightly easy option of just remaining on that ward when I finished my placement. I was interviewed for a job. They had newly qualified nurse posts, and I stayed there. It was a fantastic but sort of baptism of fire, I would say, into nursing. It was a hugely busy ward. We had 12 patients per nurse, far too many patients for the complexity of care on the ward. So after, I think it was about 6 or 8 months, I saw an advert within the hospital for an intensive care nurse training program, and one of the real difficulties that I had on the ward was that I didn't feel that I was giving the care that I wanted to give as a nurse. I had too many patients, they were very sick, and I often felt I was letting people down. So the idea of being an ITU nurse really appealed, because it meant that I would have essentially 1 or 2 patients, I could give them all the care they needed throughout my shift, and I was also going to be trained. So I then went into intensive care from the ward. I was lucky enough to do a year's intensive care nursing course, and I worked on the general intensive care unit at St George's for about, I think it was 5 years, and it was absolutely fantastic. I loved it, absolutely loved it, and really the only reason I then went into specialist nursing was I moved location. I moved from London up to Essex, and I then saw an advert for a trainee specialist nurse, a trainee bowel nurse at the Royal London Hospital. It was commutable on the train from where I was moving to, and I'd always been really interested in bowel conditions when I was on intensive care, and my own grandmother, when I was an a nurse training had actually died of bowel cancer. So at the time I didn't think it influenced me, but I think with hindsight, things like those life experiences also influenced me. So then I decided to take this post and did that for a year. So I was doing biofeedback, anorectal physiology, so essentially tests to see why people were incontinent of feces or why they were having trouble going to the toilet. And it was a fantastic training, but I wasn't sure at that stage that it was quite what I wanted to do. But luckily, through my work at the London, I met my future boss, Terry Porritt, and she invited me for interview at the Homerton Hospital, and I worked there as a nurse practitioner in coloproctology, which was a sort of a big mouthful, but essentially I was trained to be a nurse practitioner in that role. The majority of the role was as a colorectal cancer nurse, but because it's quite a small hospital at the Homerton, and the number of bowel cancers per year were smaller than some of the large London hospitals, it was also an opportunity to do training in lots of other GI conditions as well. So it was a really fantastic introduction to specialist nursing, if you like.
Well, good to be working with Terry. She introduces herself as a specialist nurse,
yes,
who we've had on here before.
Yes. She was hugely influential to me, and I had fantastic training at the Homerton. But then actually, whilst I was at the Homerton, I worked there for 4 years. I got pregnant with twins, and they were born at 30 weeks. Unfortunately, they're both fine. They're now 10, but I had to go off on maternity leave quite suddenly. Terry has very good stories about that, I'm sure, and we ended up moving house and various things, and so I actually then ended up having a 3-year sabbatical from nursing while I brought up my twins, and then I had another child as well. So I've got twins that are 10 and a 9-year-old. So I had a 3-year break, and at that point I wasn't actually sure whether I was going to continue in nursing. I had this sort of moment where, like many mothers, this isn't just applicable to nursing, where you have your children and then you think, well, how on earth am I going to manage bringing up my children and trying to get back into the workplace? But as luck would have it, we happened to move again, and I was living in Northwood near Harrow at this point. Because I'm a GI nurse at heart, I've always wanted to work at St Mark's Hospital in Harrow, which is the UK's specialist bowel hospital. And it just so happened that I saw an advert for a specialist nurse within the Polyposis Registry. I'd always had an interest in genomic medicine, genetics. I'd actually done a day's course as an introduction when I was working with Terry at St Mark's, and this seemed to incorporate bowel cancer, which I'd been training in. It incorporated inherited conditions, so I thought, well, I'm going to learn about genetics and genomic conditions, and it was at St Mark's. So I applied, and despite my break, I was lucky enough to get the job, started work there, and then after 4 years became the lead nurse and manager of the unit, and that's how I got there, basically. It wasn't really planned, but there you go.
It sounds a very interesting job, from listening to you about genomic medicine and what have you. What are the sort of most challenging aspects of the job? What are the interesting parts for you?
We'll start with the good bits, the interesting parts. It's quite different from many job roles in that I don't just work with a set of patients. Because of the inherited nature of the conditions, I work with families. And the Polyposis Registry is actually the oldest registry in the world for these conditions. It's got a huge amount of really interesting history. It was founded in 1924 by a St Mark's surgeon, Percy Lockhart Mummery, and also Sir Cuthbert Jukes, the St Mark's histopathologist at the time. And Cuthbert Jukes is now extremely famous for Jukes colorectal cancer staging, which is still in use today. So those two are the founding members of the registry, and they were hugely forward-thinking, because 50 years before any other registry was set up in the world, they had recognised that there were these conditions where patients were dying of bowel cancer, and it seemed to be running through families, and it was linked with polyps in the bowel. And they'd recognised these patients, and they started to keep a record of these families that were within their care. and they started researching what was happening to these families and why. So before genomic medicine was even thought of, before DNA was discovered, the Polyposis Registry was recording these families and trying to improve care and trying to improve survival rates for these families, because essentially the most common condition that we look after, about 50% of our patients have something called FAP, familial adenomatous polyposis, so they grow adenomatous polyps in their GI tract. These patients were getting cancer and dying mostly by the age of around 40. So these people were dying very young, and without intervention, that would still be happening. And so because of their work in identifying these patients and keeping a record, we now know that the conditions are inherited. We now know the genes that cause these conditions. We can carry out preventative surgery and treatment and lifelong care. So the interesting aspects are the care of these families, and we've got families going back literally generations, and looking at how we can improve the care for those patients. But the main ethos of the registry is cancer prevention. That's why we exist. So the most rewarding aspect is knowing that the work you do is actually stopping people from dying young. And we've got the data to show that if we weren't there, most people would be dead by 40. So that's hugely rewarding. It's such an interesting job. But like any job, there are obviously very sad aspects. No matter what we do, sometimes patients still get cancer. And you have to realise that it's not you, it's the conditions that you look after. You have to pick yourself up and you have to get on for the benefit of the majority rather than the few that you haven't been able to help. There are some horrible aspects to the conditions. FAP, they get a lot of other extraintestinal manifestations like desmoid tumours, for example, which is not a cancer, but it's a growth usually within the small bowel mesentery that can cause huge problems for patients, and is another of the most common reasons for people dying young from the condition. So there are lots and lots of challenges, and having an inherited condition and having that from a young age poses lots of problems for patients. There's lots of mental health issues within our patient cohort. There's lots of problems within families, family breakdown, and it's trying to provide not just the medical care, but trying to provide adequate care for patients that encompasses all those fields. That's where nursing is so amazing. We're obviously focused on the clinical side of things, but we're also really good, I think, at providing the compassionate aspects of that care. And that's why it's so important that nurses are involved with this patient cohort.
You mentioned in one of your interests about personalised care, and you can see when you talk about families about that personalised care for the families. Can you tell us a little bit more about that?
So personalised care has got quite a few meanings at the moment, and for me, when you say personalised care, it actually flags up things about genomic medicine, actually, because it's a big buzzword in genomics at the moment. But personalised care is really about caring for an individual rather than saying that's a group of people with FAP, that's how we're going to treat them. There has to be some of that, but it's about taking the condition and seeing how it affects that one person and giving them the best care for them. And you can filter that through to genomics. So genomics is, we used to call it genetics because we were looking at little bits of the genetic code, if you like, but as things have moved on in the last 10-20 years, we're now looking at whole genome sequencing, the sequencing of a patient's whole genome to provide real-time information about predicting disease, preventing disease, diagnosing conditions and treating conditions. So it's about, rather than saying like FAP or like diabetes or Crohn's or breast cancer or bowel cancer, rather than saying you've got this condition, this is how we treat the condition, it's about the person. One size doesn't fit all. It's about how your genetic or genomic influences are affecting the disease that you have. And everybody has a different response to disease. So, in the future, we're not going to be saying, this is how we treat bowel cancer. We're probably going to be saying there are similarities between certain types of breast, bowel, lung cancer. It's about the tumour signature, the genetic signature of that tumour and how we treat that, rather than putting these conditions into groups and treating the conditions. So it's about changing the way we think about how we deliver the whole of healthcare, really, and that's why it's so fascinating to be within this field at the moment.
Sounds quite advanced. One thing that I always like, you know, when we talk to nurses, we always like to hear that they always talk about the treatment of the patient, but they always talk about how you treat the families. And it's always interesting, you know, and I always ask, you know, many people have been on this, you know, where do you learn that? About how you then communicate and those softer skills, you know, but nurses seem to do a lot of that as part of their role.
Yes.
How does that come about?
You can't learn it just by going and doing 3 years of a nursing course. You have to be in role to do that. And I look back at my 22-year-old self when I first qualified, and I'd probably be horrified if I followed myself around and saw how I communicate with people, because you don't have the life experience. That's why I think it's such a shame that the bursary has ended in many ways, because one of the huge positives to nursing is the number of mature students that come through our doors, and I think they add another dimension because they've done different jobs, they've got different life experiences, and I think that is why we quite often communicate so well, because we come to nursing with a different background and different life experiences. Now I went to university at 18. I don't think that's a particularly good way to come into nursing, actually. If I could say anything to the 18-year-old that I was then, I would have said go travelling, maybe do a different degree and do a postgraduate course in nursing, but maybe come into it in a slightly different way to get some different life experiences to be able to assist in how I do those soft skills, the communication. Because I do think things like having premature children, for example, and being you know, at the receiving end of NHS care hugely influenced the care I give today. You know, having a grandmother that died of bowel cancer influences how I speak to patients now, because I can say that, you know, I've got family experience. Last year, my own sister was diagnosed with bowel cancer at a very young age, at the age of 38. So now I can truly say to people, you know, I don't have experience of having polyposis, but I do know what it's like to have a bowel cancer running through the family. Luckily, ours isn't an inherited cancer that runs through the family, but it's that sort of life experience that really assists with your role, and you simply can't teach that. You have to learn by experience, and as nurses have more and more years experience, that's why we get, you know, so expert at all those skills of caring for not just the patient, you know, but the family as well.
Yeah, when you talk about the experience, I think that's how the Hello My Name Is campaign came about.
Yes, yes.
You know, because Chris always says, you know, when he was there with Kate, when Kate was getting treated, the nurses weren't introducing themselves, and that's how a whole campaign has come about, that always focuses on personalised care and people introducing them, say, hello, my name is Adrian, talking to the actual patient, as opposed to coming in and just doing bloods and walking off. But that all came about from and she was a doctor going.
I know, and a lot of people, some people have said, well, you know, that campaign, we shouldn't have to teach people to introduce themselves, but I think that opinion doesn't allow for people appreciating how stressful and difficult work on the ground is in the NHS at the moment. And you do not want to be that person that hasn't introduced themselves. You don't want to be that nurse that hasn't communicated effectively. But if you have a huge patient caseload and you're understaffed and you're very busy, those skills sometimes can go missing. And I think, who is the best person to tell us where we're going wrong? It's the patient at the receiving end of care. And when you have clinicians, nurses, doctors, allied health professionals that are also patients, that's amazing, because their care can then feed back into the care we're providing. So it's not a negative thing. I think it's an amazing thing that we've taken it on board. We've gone, yes, actually, we do need to improve. You know, I'm always very happy. I like people to tell me if they're not happy with something I've done. I want to improve. I want to make sure that I'm doing the best job that I can. We have moved away from the sort of, you know, start of NHS paternalistic model where, you know, the doctor told you what you needed to do and you had to do it. You know, the patients themselves have a level of responsibility for their care. You know, when I look at my families within the registry, there are certain things that I can do, but I only have, you know, a 15-minute clinic consultation with them. I have a telephone consultation with them, the majority of their life they've got to lead. And so it's a partnership, and it has to continue to be like that.
Yeah, I don't think they're teaching Hello My Name, I think more of a reminder, because as you say, if people are under pressure, sometimes you forget the small little things that are needed, and you say that's the personalised part. And nurses, as we always talk about the care aspect, where sometimes with the element of the doctors is the clinical, right, this is the solution, but the care is always from our nurses. Talking of hashtags, the Never Too Young campaign, tell us a bit about that.
Well, I mean, I became obviously very interested in that campaign when I started working in the Polyposis Registry, because I work with a group of very rare conditions, but rare isn't actually that rare. 1 in 17 of us have a rare condition. So actually it's just that the different conditions on their own might be super rare, but collectively it is not that rare to have a rare syndrome. But it is difficult to get the word out to GPs and other clinicians sometimes, because if you've only got one patient in your GP surgery with FAP, for example, or Peutz-Jeghers or juvenile polyposis, even more rare, you're not going to quite rightly know anything about those syndromes. So I remember watching an interview, I think it was on This Morning a few years ago, where they were talking about bowel cancer, and there was a GP saying, well, young people don't get bowel cancer. And I felt like, screaming at the television, because young people do get bowel cancer. Of course, it's much more rare to get bowel cancer when you're young, but around 2,500 people were diagnosed with bowel cancer under the age of 50 last year. And the figure is rising. I think it's rising by a huge figure year on year. We don't really know why. I'm sure that environmental and genetic influences are playing a part in that, but we need to listen more to our young people when they're going to the doctors with symptoms, and we need to not just say, oh, you've got irritable bowel disease. Irritable bowel disease is a condition that's diagnosed or should be diagnosed when every other option has been exhausted. If somebody's revisiting the GP over and over again with symptoms, it needs to be investigated. And the Never Too Young campaign has been great in highlighting that, and it's about awareness. It's about awareness of clinicians, but it's about our awareness, because if we don't know the symptoms of bowel cancer, then we might not be worried. If you're young and you've got a bit of bleeding from the bottom and it doesn't go away, you say, oh, I've got some hemorrhoids, some piles. If you've lost a bit of weight recently and you feel really tired and exhausted, you're like, oh, well, I'm a new mum and I've got children and that's how it is. Not that I've got anemia, and that's actually quite worrying. So we also, as patients, as part of the general public, we need to be aware more of our own health. And so it's a double-sided story there. Both sides have got responsibility, and I think things like the Never Too Young campaign are important because they're raising awareness. And social media, again, I love social media. I love using Twitter. It's vitally important for trying to get that message across, and nurses need to be more engaged. There are lots of nurses that are very engaged with social media, but I think that more and more of us need to engage with it, because it's a fantastic leveller. It's a fantastic way of getting involved in projects, speaking to people at all different levels of nursing and healthcare. It's one of the reasons I'm here today. We're talking about lots of different things, but that campaign is vital, but it's vital in lots of different ways, from using social media to raising awareness, to getting both clinicians and patients or the general public together as well.
Yeah, I suppose, as you say, it's raising the awareness, isn't it, for the general public, that it's not just I've got to sort of start, whatever the issue is. It's like, no, it could be serious, and also for GPs not to, as you say, to understand that there might be more serious ramifications out there as well. Yeah,
and obviously I've got now a personal connection with it, both through my work and through family diagnoses and things, and what the work of Bowel Cancer UK is doing is amazing in raising that awareness, and they're hugely supportive of all different aspects of bowel cancer care, and even for conditions like ours, where the hope is you don't get bowel cancer. That's our whole ethos. But obviously our patients sometimes miss out because they don't have the cancer diagnosis. There's so much support now, quite rightly, for people who have a cancer diagnosis, but the support can somewhat be lacking, especially especially in areas of mental health, for people that might need that support, haven't got a cancer diagnosis, but have this terrible sort of condition that's hanging over their head. So there's lots of different avenues really to it.
If we talk about nursing as a career, what would you looking at someone going into nursing now? What would you be sort of, tips of advice about maybe why to go into nursing, but also what to look out for?
I think nursing is an amazing career because it's so varied. I think the problem is that the public perception isn't good enough, that people don't realise the varied nature of the job. I had no idea when I went into nursing what nursing really was or what it entailed. We generally think of nurses as, district nurses in the community, or we think of nurses on the ward caring for you after you've had an operation or when you're not very well. But that's literally hitting the tip of an iceberg. I would never have imagined when I started training that I would be leading a unit that looks after people with inherited conditions. So it's the hugely varied nature, and it's the positive change that we can make. Nurses have always been innovators actually, but we never shout about it. We tend to stand in the background. We tend to say things like, oh, I'm, one of my pet hates, just a nurse. If anybody ever says that to me, I correct them. You are never just a nurse. You are somebody who is having a huge impact on care. We're changing care. We're trying to make improvements. Like things like the Academy of Fab NHS stuff and things like that. So it's an absolutely fantastic career, and I think we need to get the word out. So we need to improve public perception. We need to make it a viable career choice for school leavers. It isn't a viable career choice at the moment. There's so many negative press about it. Nursing pay isn't what it should be, without a doubt, but it is on a par with certain other professions. It's not as terrible sometimes, I think, as people perceive it to be. It should be on a school leavers list of jobs. It's an amazing career. So we've got to improve the perception. We've got to get the word out about nursing, and we need future nurse leaders. So we need those, academically minded, compassionate, caring people to see it as a career option, to provide us with the leaders for the future, to keep that voice going. I think it's a really hugely exciting time for nursing. I wouldn't have said that actually maybe 2 or 3 years ago, but I really believe that now, despite the negative press. There's so many technological advances. Obviously, I'm in a very exciting field with genomic medicine at the moment, which will really take over how we care for people.
There's so many different avenues you can go down, as opposed to that's what you do and you sit on a ward for the rest of your days, or you're in A&E for the rest of your days. It's so varied, but you don't learn that in schools. No. And that's not raised as an option. No,
and part of that varied nature is because nurses have innovated and seen opportunities and taken those opportunities. Within my role, although I see myself 100% as a nurse. I'm a nurse practitioner, so I run my own nurse clinics. I also manage, so I have to manage a team of staff. But I also do a lot of research. That's another aspect of my job. So far in my role, I've travelled to Australia, I've travelled to Brazil. Next year I'm going to New Zealand. I've been to Florence, presenting and getting our research across at international conferences. You couldn't have told me that I was going to do that when I was 18. And I've been lucky enough to be able to make that role my own and decide how I want to progress that role for the benefit of my patients, but also it's benefited me as well. And I think that nursing, we need to have probably better formalised career structures in place so that we can say these are the sort of careers you can go down. If you want to become a doctor, you know that you're going to be a junior doctor for a number of years, you're going to have a set career path, you're going to pick your specialty, then eventually you're going to become a consultant or you're going to become a GP, various other things. It's not quite as simple as that. There needs to be more formalised pathways for nurses. One of the things that I feel quite passionately about is that ward nurses, for example, don't get the education and training that they so desperately need because of staff shortages. Ward nursing is a specialist form of nursing, and it should be treated as such. all of these different aspects of nursing are, and they need to be provided with the education and tools so that they can do more innovating and take things forward. So it's not just a case of, oh, I'm stuck on the ward. It's, I've chosen this specialist subject. I'm going to be, a St Mark's colorectal ward nurse, and I'm going to innovate in these ways, and I'm going to ensure that every patient that has surgery, has amazing outcomes. And we're getting to that point, but we need to work on that much more to make it a much more attractive career option.
I think also you talk about the management, the support, about how do you start managing people? Where does that come from? I know Teresa does a lot with Apollo, but giving here's your business plan, here's your budget, mate. And sometimes nurses are just dropped into that role.
100%.
And it's that support, and that's sometimes where a lot of stress can come, because you're doing stuff that you're not trained for.
That's right.
And that's one of instead of I'm here to look after patients. Well, wait a minute, I've got to do all this planning, I've got to do budgeting. They're managing other people. They're like, how do I?
As nurses, you have to take on the responsibility for training yourself. If you don't ever want to read a paper on your specialist subject of interest, if you're not going to take yourself out, do the required courses in reading, then you're not going to progress. And I think there's always been the idea that the medical side of things has always been, we've got to learn all the time, whereas a lot of nurses sometimes I speak to will say, well, I don't have enough time, or I'm too tired to read a paper in the evening. Yes, of course, but there has to be a certain level within yourself of driving change and driving yourself forward. But for example, with Apollo nursing and things, that's been hugely invaluable to me when I took on the management role. But for example, when I thought that the management role may be coming up, I put myself on a leadership and management course that was running at the hospital, because I recognised that I needed to educate myself with extra skills. The hospital would have just given me that job had I not been on that course or not. In some ways, nobody's going to say, here's the training, here's the job. Unfortunately, that's how it should be. Yeah. But a lot of the time, you need to do it yourself, and you need to know where you want to be. You need to be maybe a little bit more organised than I've been. But I also think that on the job you need to recognise what assistance you need. So for example, I have regular meetings with the clinical director of the unit where I work to provide that extra support. You meet with the lead nurse to ensure that you're getting support, and you have to be quite proactive in getting support. I could just sit back and say, I'm not supported in my role, I'm really unhappy. But nobody, unfortunately in NHS, everybody's so busy that nobody's going to say to you, Vicky, this is a package of support for you. Unfortunately, of course, that would be the ideal, but you also have to be very proactive in reaching out and making sure you've got that support.
So obviously Apollo is a good resource.
Fantastic. Yes.
Colleagues are a good resource. Is there any other resources you'd recommend for our nurses to be looking at if they're looking to develop themselves and learn?
Well, there's loads of amazing online courses now. Depending on your specialist interest, always know how to do a literature search. And if you don't know how to do it, ask somebody. Okay. So, PubMed is your friend. If you're on the ward and you're not quite sure what the surgery is involved, if you're on a surgical ward, for example, and you think, I don't really know what's involved with that, J-pouch surgery, for example, that's fine. But then it's up to you to go home, do a search, and find out exactly what that surgery involves, or ask the questions. Do ask for regular meetings with, if you're on the ward, your clinical supervisor or your mentor. Make sure you're up to date with your appraisals and things like that. It's down to you to make those appointments, to make sure that you're getting that support. It's not easy. I'm not saying, it's all down to us and it's really, there are lots of limitations, but unless you are proactive, you're not going to drive yourself forward. Speaking to medical colleagues, shadowing different people if you can, applying for different jobs. I've often worked with nurses on the ward who've said, I've said, there's that job coming up, what have you ever thought about doing that? Oh, no, I couldn't, I'd be hopeless at that. Do you mean you'd be hopeless? I think that's a problem with underconfident sometimes within the nursing profession, and that voice I was talking about earlier. We need to put ourselves forward for things, and realise that we can do different things. There's lots of ways of accessing it and accessing information, but quite often you have to be the driving force. It's not just going to come and be dropped in your lap, unfortunately.
No, we had Dr. Ramesh Prabhu on, and he talks about leadership, but he always talks about continuous feedback.
Yes.
That's how we improve. He said continuous early feedback.
Yes.
He said that's what you do. So we need to ask for it sometimes. If you haven't got the leaders in place, then can give you that.
Yes.
So it's a two-way street. You might have a great leader who's always giving you continuous feedback, but sometimes you have to ask for that to help you improve.
Yes, definitely. And the leaders themselves, how do I know that I'm doing a good job? I really don't. When my appraisal was coming up in March of this year, I did a quick survey monkey of the nurses that I work with, because I thought, I don't know, how can I sit in front of the lead nurse and say, oh, I'm just so amazing, I'm doing an amazing job, how do I know? And it's really interesting to get some of that feedback, and some of the areas where, I probably thought, oh, I've got that covered, and I thought, oh, maybe I need to improve in that area, or maybe I need to improve in that area, and some of the nurses saying to me, we want you to mentor us more in how we can do various things. So then, that came out with me having a chat and saying to them, well, you've got to come to me and say what you need. And so the leaders themselves need to know how to improve, and I think it's all too easy within the NHS to be given a job, get so snowed under, and then not be given the tools to do that well. You're almost doomed to failure in a way. And I do think that side of things, there does need to be more support from the NHS. I think it is changing. I think trusts are cottoning on to the importance of staff well-being, of setting up different programs, and there's a lot more that you hear about things like mindfulness for staff and things like that. But it's whether staff can access that. It would be easier for me quite often I'm in an office now, funnily enough, but it's easier for me to say, plan in going to a talk on mindfulness maybe than it is for a ward nurse who comes and does the shift and then has to go home. And it's almost like that sort of thing needs to be regularly timetabled for staff. It needs to be as essential as being on that ward. These things cost, but it's a cost that is negated by not as many staff absences, retaining your staff, the huge cost of recruiting staff, when we could just retain the excellent ones we've got if we treated them better. And then, unfortunately, in this cash-strapped NHS, the upfront costs are seen as too much, but it's okay to be spending all those costs down the line, as we can't recruit staff, we're doing agency spend, we can't retain the staff, and because people are getting burnt out. And that's another huge area that hopefully will be worked on in the future.
Yeah, I think one of the biggest things that we keep hearing about, for nurses, is the stress they're under, and the mental health aspects that they are really, healthcare professionals sometimes seen as infallible. They don't make mistakes. We all make mistakes. That's the world we live in. We're all human. But a lot of the feedback we get about nurses at the moment is the stress and the mental health pressures they're under, and the avenues to try and relieve some of that stress.
Yeah, I don't think, again, that the general public can perceive exactly how stressful being a nurse actually is. It's stressful in a fantastic way, because at the end of the day you go home and you think, I know that my job is really useful. It helps people, basically. And if I wasn't doing my job, what would happen? Not everybody has the privilege of being able to say that. But we don't look after our nurses. Do I feel looked after? Probably not most of the time, but I do the job because I love it, and I'm there for the patients. And I think we do need to really think about setting up better programs to support the mental health of staff. But how are we going to do that when we already know at the moment that mental health provision for our patients is so poor? It's been all over the news recently that there's a huge hole in mental health provision in this country. I know that from the work that I do. I often think my patients deserve more in the way of mental health provision, but trying to get them even a counsellor locally or to get specialist provision for their mental health is nearly impossible. You're not providing that all-round care. So if we can't do that for our patients, how are we realistically going to also do that for our staff? So it's a huge project. It doesn't mean that we can't start getting on and doing something about it. But it's something that's going to take quite a lot of time to implement. But it's all like we were talking about earlier, those costs. Yeah. They seem like a cost, but they would definitely save NHS money in the long run.
I think if you don't look after the healthcare professionals, then who's going to look after the patients? Because you say you get burnout, people leaving the profession. We have an aging population throughout Western, with the Western world. We need to look after that knowledge as well. Because as you rightly say, some of the nurses, the experience they've had over the years, you might have a doctor, but they're actually teaching the doctor what to do because they've got the experience and the knowledge. You want to retain that, but if they're too stressed or they're too tired, they're just going to leave the profession. And all that knowledge just walks out the door with it, and that happens a lot now. Yes,
that is happening, and I think that quite often, if you're stressed enough to maybe need to seek help from occupational health, or if you've seen a terrible event, maybe a patient you've been looking after for a long time has just died. Quite often it's just seen as, oh well you're a nurse or you're a doctor or you're a physio, that's just what you do, isn't it? Crack on and get on with your day. And actually we need to recognise that when stressful events happen, that member of staff needs to be taken out. It should be the norm to receive that provision. And if it was normalised, then we wouldn't think twice about it.
No.
I've read various medical books recently. There was the comedian Adam Kay with his book about being a junior doctor. There's obviously a fantastic book by Christy Watson on nursing, and it's quite obvious that we're not protecting the mental health of our staff, and it should be the norm rather than, I can't possibly phone occupational health because that would mean that I'm failed in my role. Actually, isn't it more normal that we feel during periods of our profession where we feel quite down, where we feel sad about what happened? It's more abnormal for us to carry on as if nothing has happened when stressful events occur. And we are creating a generation of people that aren't compassionate, you could argue, by not looking after their mental health. And that's why it's so important.
I think there's more of a public awareness, isn't there, that it's okay?
Yes.
We're trying to change that stigma of mental health is, white jackets and things like that. You're trying to change it and go, no, this is just part of your health. Yes. You physically go to the gym, all that sort of stuff, yes. Try and keep your physical well-being. Yes, you have to look at your mental health as well. We're trying to raise awareness when you've got people like, heavyweight boxers like Tyson Fury, who's very public about he's had some challenges. Yes. And it's just raising that awareness, going, this is part of life. It's okay. And then making sure that nurses maybe look after each other. More about if you see a colleague going, are you okay? Yes. Rather than, some big thing they have to report and, as you rightly say. And look at that compassion.
And I think that's why things like social media is so important. And the younger generation are so important because they're not so worried about things like this. They recognise far more than we do about its importance. And they're willing to share their stories and share campaigns on things like Twitter. And through that, and through healthcare professionals using Twitter, we're more likely then to engage. The tide is definitely changing. It's changing for the better. You've got apps like Calm and what have you that you can just tap in and, try and do your few minutes of breathing or what have you. But obviously the problem is you have to do that. Yeah. And sometimes you need to be in a course, or you need to have somebody facilitating that to actually make you do it. The tide is changing. It will come. It's just that we need to keep the momentum going, basically.
I'm talking tide change. What do you sort of see as the main trends over the next 2-3 years in nursing?
Well, not just because I'm biased, but personalised medicine. The influence of genomics on our healthcare is already happening. It's going to be huge. 2 years ago, the Chief Medical Officer, Dame Sally Davis, produced her report, what was it, the Future Genome? I'd have to check the name of that. Fantastic report, sort of encapsulating all the areas where genomics is going to play such an important role. If you think of health promotion, if you think of how we're going to predict whether people have got disease, we're going to be able to do whole genome sequencing and say this group of people could be more at risk of, this virus or this cancer or having a bowel condition, for example, and we can predict disease better and therefore we can treat it better. So
there'll be more preventative care as opposed to waiting till it strikes, kind of.
That's right. So you're going to have huge impact on that. Cancer care. Huge area where genomics is going to have or is having a massive impact already. We're doing sequencing of bowel cancers, and we're deciding whether or not to give chemotherapy based on that, because there are certain tumours that don't, certain mutations that don't respond to chemo. And chemo is a horrible set of drugs, so why would we give that to somebody if it's not going to help? So it's going to revolutionise things like that. Pathogen genomics, think about the Ebola virus, about going into the field using amazing handheld gene sequencing devices in developing countries, where you can go along and you can take somebody's blood in the field and sequence that whole genome and decide how you're going to provide the best care for that outbreak, that virus that's devastating that population. So there are huge, fantastic advances that are happening in genomics at the moment. Rare disease, common diseases where there might be environmental and genetic factors playing a part. So prediction and prevention of disease, diagnosis and treatment of disease are all going to be completely changed by the advent of genomics in healthcare. And then for nursing in particular, nurses have got to get on board with that. I present quite a lot, and often nurses will say, we don't know anything about genomics. And I say, you do, and I give them examples of how it's already being used in their area of care, and I'm like, I didn't realise that was genomics. Okay, right. And I say,
give us an example.
So, for example, if you've got Crohn's disease and you're having azathioprine, you do a gene test, you do a blood test before somebody goes on that medication, to see about how they will respond to the medication, and you will dose adjust that medication depending on whether they've got this genetic alteration. That happens a lot. We call it pharmacogenomics. So it happens a lot in medicine. If you're going to have HIV treatment, you often have a gene test to check that you will respond, because some people respond too much to certain drugs. So you could give a drug and it could kill them. So there are lots and lots of different examples.
People don't realise that's genomics.
That's right. People go, that test we do before we give azathioprine, it's just a blood test. I said, yes, it's a genomic test. It's a genetic test. You're looking to see somebody's response, you're predicting response to a drug, and you're testing a gene to see how they might respond to that drug. We're already using it. It's in common practice. That's going to be built upon, and nurses could, if they choose to be at the forefront of this. There's so much education and information out there, but like I was saying to you earlier, we need to harness that. So Health Education England have got a fantastic genomics education programme, and they put on loads of free courses, online courses through FutureLearn. So you can go on, you can sign up to free online courses, you can teach yourself genomics. That's how I started learning myself. I'm now being fully funded to do a master's in genomic medicine through Health Education England. There's huge, amazing opportunities that have been afforded to me, because at the moment there is that drive to upskill healthcare professionals in genomic medicine. But we need to realise and grab it and get on board with it. Nursing shortages, it's always going to be a trend, and how we tackle that. And some of the things we discussed earlier about getting better career pathways, getting teenagers to see it as a viable career pathway, those things will help. And technology is changing massively. It's part of the genomic revolution. How we harness technology, how we remain at the forefront of healthcare by ensuring that we've got the technology to compete in that healthcare arena. I think that's probably the main ones at the moment.
Very good. And tell us a bit about what you're doing outside of work. Obviously, three kids, and reading everything about genomics.
The work and children keep me incredibly busy, and work never stops. I'll always be reading articles and things, because things are always changing so much. But obviously, spending as much time as possible. I work full time. The NHS is an amazing employer in many ways. I work 4 long days, so I can drop the kids off and take them to school on Fridays, and spend my weekends doing activities with the kids and seeing friends, trying to spend time with friends, doing relaxing things, going out, meeting friends and things, to look after my own mental health after a busy week at work.
Very good. And just to sort of finish up, is there any sort of message you'd like to say to our nurses that are listening to this today?
Well, to the nurses today, I would say please, please, please gain an interest in genomics, because no matter what field you're in, whether you're on the ward, whether you're a specialist nurse, genomics is coming or is already in your area of nursing, and you need to recognise it, you need to see the opportunities for improving care for your patients, and you need to grab it. I would say nurses, speak out, have that voice, realise that you have an important voice and that you are innovating all the time, and we need to shout about it. And I would say, you know, educate yourself. Nobody's going to educate you. You have to speak out. You have to grab the opportunities that are afforded you, and you have to, you know, do that reading, get on those courses, and make sure that you're the best that you can be for your patient. And to all those that are thinking of coming into nursing, I would say do it. You know, it doesn't matter where you are in life. You know, I know there are issues with the bursary having been scrapped at the moment, but we need school leavers, but we also need mature students to come into nursing. It's such a fantastic career. I can't emphasise it enough. And, you know, if anybody wants to get in touch with me and ask me more questions about it, then I'd be very happy to answer.
Where can they find you? You're on Twitter?
So, yes, my Twitter handle is at VickyChas3. Obviously, I devised that when I was on maternity leave. And at Polyposis Reg UK as well. I run a Twitter feed for the unit where I work.
We'll put that in the bio as well.
Yeah, so and my email address as well, we can put all that in the bio. So, you know, people are very, very welcome to get in touch with me.
Vicky, thank you so much for your time today. Really great to speak to you. Great to learn about genomics.
It was really great to be here. Thank you for asking me. Thank you.
Thank you for coming to the Voice of Nursing. Thank you to all our nurses, healthcare assistants and doctors for looking after us all. We'll catch up with you soon.